Thank you for joining us for today's webinar on uterine fibroid embolization, also known as uterine artery embolization. We are joined by Dr. Swenson. We also have your physician liaison, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis can stop by for a visit at your practice. Dr. Jason Swenson is a board-certified vascular and interventional radiologist and has been practicing physician with Charlotte Radiology for over 10 years. Dr. Swenson completed his residency in diagnostic imaging at the University of Michigan in Ann Arbor, Michigan, and completed his fellowship in interventional radiology at Johns Hopkins Hospital in Baltimore, Maryland. I'll now pass it over to Dr. Swenson to begin the presentation.
Thanks for that introduction. I can't believe it's been 10 years since I've been with Charlotte Radiology, but it has been. And this talk is really going to go over all kind of the changes in uterine embolization over the last 10 years, kind of an update. But yeah, 10 years. I showed this slide to my daughter who's been on Zoom for the last year, and she gave me all these tips like, too many words and, all these transitions, not enough pictures, but hopefully this is okay. So then she asked me, Dad, are you nervous to talk in front of people? And I said, that doesn't make me too nervous. I'm okay. I said, you guys make me nervous, right? When you're really quiet upstairs, I get nervous. When you ask me, we're in my car, and you ask me where your chocolate bar is, I get nervous. And when I come home and find those stray marker caps all over the house, then I get nervous. But this I got. So she said she'd watch it afterwards. So we'll have to say I have to do a good job for her. But basically, this is, like I say, an update on uterine artery embolization. We're going to just talk about really what the procedure is briefly. And I assume most people that hear this talk have some idea. And then I'm going to go into, what's different, what's new, what have we learned in the last 10 years? And so I'll start. I see do you guys see that? I'm going to move that over. So uterine fibroids, they're very prevalent, right? Approaching 80% in Black women, approaching 70% in Caucasian women, and 50% have symptoms. So it's the most common benign neoplasm of the pelvis. And the biggest symptom is bleeding, and that can cause anemia. And then there are all kinds of bulk symptoms: bladder and bowel dysfunction, abdominal protrusion, dysmenorrhea. So lots of symptoms and a lot of patients that are treated. And a lot of times these patients are treated with hormonal therapies, lots of non-surgical therapies. And we're really talking about the patients that don't do well with those and need to have something else done. So uterine artery embolization was first performed in 1985. That's when it was first reported. So like 25 years ago. So quite a while. And really the same idea hasn't changed. What we're doing here is this is a minimally invasive procedure. This is a procedure that's done with a small catheter in the artery, and we actually advance it to the uterine artery, and then we basically inject tiny plastic particles. And these plastic particles are like the size of grains of sand, and they're all designed to be a certain size, and we basically embolize the uterine artery. And by embolizing the uterine artery, we starve the fibroids. So there's two terms for this: uterine artery embolization and uterine fibroid embolization. And these are basically the same procedure. And sometimes you'll see them both used. And sometimes in this talk, I'll probably use them interchangeably. And I actually did a PubMed search, and that's what these graphics are showing. The top is showing basically how often uterine artery embolization is cited in the literature and how often uterine fibroid embolization is cited in the literature. So 2,500 times for or 2,500 times and almost 1,600 times. So this terminology is not going to change. Unfortunately, we're kind of stuck with both of these terms. And like I say, I'll probably use them interchangeably, unfortunately, too. And I think that's a little confusing for patients, but they talk about the same procedure. We're also talking about, 4,000 studies that have been done since 1995. And I said the general idea of this procedure hasn't changed. So what has changed? What are we publishing 4,000 studies on? And that's kind of what I want to talk about. This procedure went from a procedure that was kind of notoriously painful, that required PCAs and hospitalizations. And nowadays, we can do this procedure as an outpatient. We don't use PCAs afterwards. We discharge them. Patients are asking to go home. So I want to talk about the changes that have happened since 1995 that we get to this point. Because I think a lot of people, even some of our referrers, are familiar with those changes. And so that's going to start out with what we know about patient selection. And then I'm going to go into some procedural changes, and then I'm going to finish with post-procedure care. So patient selection, basically patients that are candidates for this have symptomatic uterine fibroids. And these are basically patients that failed other treatments that are going on basically to surgery. So the patients are considering myomectomy or considering hysterectomy or considering probably uterine artery embolization. That's the kind of cohort of patients we're talking about. And I highlighted this because I think this is something that we could definitely improve in this market, collaboration with a gynecologist. And the reason I say that is in a lot of academic centers, these are done collaboratively. A lot of times there's offices set up in GYN or with GYN. And here, we get great referrals from a lot of great gynecologists. And I appreciate every one of those. But we also get a lot of self-referral for patients that are really offered, they aren't candidates for myomectomy, they're offered hysterectomy, and they actually find us. And we've marketed to them. And I think this kind of needs to change. I think that we have a better patient selection. We actually reach the right patients with more collaborative effort. And that's something it's not going to change with this talk, but it's something I'd like to see change. I think there'd be, like I say, better patient selection. Even if we're not doing a lot more procedures, I think selecting the right patients is going to have a better impact for really that care of this area. So anytime we see a patient for UAE, we always see them in consultation. We always have a clinic visit. We talk to them about the procedure. We review all their prior imaging, usually ultrasounds, and either prior to the consult or actually after the consult, they get an MRI. And an MRI is really important in uterine artery embolization because it's telling us, all the things that we're not going to see because we're not opening the patient up and looking surgically. That's telling us location of the fibroids. It's telling us if the fibroids are enhanced, if they're getting blood flow. It's telling us stuff like if there's other pathology, such as endometriosis, that we wouldn't be able to tell from an ultrasound. So there are very few contraindications to this procedure. And really the contraindications would be viable pregnancy, active infection, or cancer. I mean, outside of those three, true contraindications, the rest of it is all more relative contraindications or more that require special attention. So I listed a few things here, and then I'm going to go into some of the things we've kind of learned about the procedure over the last years. So contrast allergy, renal impairment, coagulopathy, these are all things we manage. We do a lot of angiograms. Contrast allergy, we prep the patient or we use CO2, same thing with renal impairment, and coagulopathy we can kind of manage. And then basically I mentioned this already, fibroid imaging, all the stuff that we're going to get from the MRI, that's why the MRI is so important. And I'm not going to spend a lot of time on this, but basically this just shows you kind of how a lot of our reports are structured, our MR reports are structured. And this, it used to be very important. I still think it's important. And it's important for a couple of reasons. Sometimes we want to know if there's submucosal fibroids, and I'll talk about those because that has to do with, fibroid expulsion. And sometimes there's subserosal fibroids, and those have a special or need special attention. Now, this talk is different than most talks I give. I've been spending the last decade of my life doing angiograms, and I love talks where they show these crazy cases. And I actually took all the angiograms out of this because if you do it, like you see something crazy and you're like, oh, I'm going to try that. We can do that at my hospital or my lab. But I find if you don't do a lot of angiograms, I show you a bunch of angiograms, you just don't. Even if I explain it to you, it's hard to get you excited about it. I think it's kind of like probably like K-pop. If you're into it, that's great. But if I have to explain it to you, it's probably not going to be your thing. So no angiograms. And this is probably one of the only pictures I have here. But I'm going to talk now about specific cases where we actually, we basically know a lot more. So adenomyosis is basically a endometrial ingrowth into the muscular area of the uterus. And this used to be a reason that we would kind of wonder if they're going to get a good treatment if they have adenomyosis. It's something we can clearly diagnose with MRI, and we make that diagnosis a lot. The problem with it is it can mimic the symptoms of fibroids. So if they have adenomyosis, the question is often, should we treat these patients, or does this patient need a hysterectomy? And that question's really been answered. And it actually turns out that, yes, they do actually get improvement, similar to patients that have fibroids. So, but actually probably somewhat less so. And that's something I would counsel these patients on. There's actually a bunch of predictors that can tell you if they're going to do well with adenomyosis. So if the adenomyosis is focal, they tend to do better versus diffuse. Or if the adenomyosis is low on T2. And we also use smaller particles when they have adenomyosis versus just fibroids. But all these things come into play. And we actually counsel these patients pretty well. If they have a favorable profile, these are great candidates, like 82%, which is actually slightly less than without adenomyosis. And if they don't, then it drops below that. But again, it's information we had where we didn't have it, kind of years ago. It kind of counsel the patients well. So intrauterine devices, this was another issue. Do we treat patients that have intrauterine devices? We used to send the patients to have them get their intrauterine devices removed prior to fibroid embolization. And it turns out that the concern was that does this cause infection? And there's been large studies now that have shown that we can treat these patients. There's less than a 1 in 1,000 risk of infection in retrospective studies, and they're actually small negative prospective studies. So if the patient doesn't need their intrauterine device, is planning to remove it anyway, it makes sense to remove it prior to the procedure. But if they want contraception afterwards, it makes sense to leave it in. UAE and postmenopausal women, for years I would tell my PAs that we don't treat postmenopausal women because the fibroids should regress. And it turns out, as I should have known, but a lot of women with obesity tend to actually have persistent new fibroids or have hormone replacement therapy. These things where there's higher levels of estrogen, and there's actually studies that show with patients with bulk symptoms, they do well, actually just as well as patients that are premenopausal. So it's not an absolute contraindication. Although I think this is again a discussion. How long would you want to wait after menopause, those kind of things. But a question that was answered. And then this was another issue is large fibroids. Sometimes people say, well, this is too large to do a UAE in. And there's been many studies that show that it doesn't matter the size. Some people use 10 fibroids greater than 10 centimeters, these mega uteruses that are greater than 24 weeks or 1,600 cc volumes. All of these have been shown to be safe and effective. So the size of the uterus doesn't matter. And actually, it doesn't even correlate very well with outcomes afterwards, with the exception of maybe some bulk symptoms. But for bleeding and things like that, it doesn't make a difference. So I mentioned this kind of briefly, but pedunculated or subserosal fibroids, these are the fibroids that are obviously hanging off the uterus into the abdominal cavity. And the question was always, can we treat these patients? And the answer is yes, because the stalk that's connecting this fibroid to the uterus doesn't necrose. It's not actually part of the fibroid. It's actually more tissue, like the bristles of the myometrium, or more fibrous tissue. And there's many studies, histologic studies, that show that this does not necrose. And so you can treat these. The one thing I make note of, though, is actually they tend not to necrose as well. And the thought is that there's only one vascular supply to a pedunculated fibroid, and they could actually recruit blood flow from other places like the ovarian artery or other pelvic arteries. So they actually have a higher rate of failure. So again, important to know, not because of risk of infection or causing an abscess in the belly, but you have to be careful with treating these and looking for other vessels. So that's kind of, I talked about those patient selection and things that we've kind of found. And I really think that's important because a lot of those questions were questions about, which patients should we treat? And if we select our patients well, obviously our outcomes are going to be better. And I think a lot of this has to do with patient selection. And again, I reiterate again, I think that's why a collaborative setting where we can have these discussions would really for better patient care. And that's something, again, something we need to work toward probably in this market. I'm going to switch gears and talk about the procedure. What's different? I say this is a better procedure than it was 10 years ago. Why? And this is just one of the differences. So procedural access. Most of the time we always did these from the femoral artery, a common femoral artery access, go up into the pelvis and treat this. And it works well, but a lot of times we'll do these radial now. And the reason to do them radial is patients can ambulate immediately after the procedure. It's actually easier to see if they have any kind of bleeding at the site. But this is not one's better than the other. You know, there's advantages with a radial access and that early ambulation. Don't have to use a closure device, which we do on femorals typically, just so they can ambulate earlier. But it's not like there are disadvantages with radial access, right? They have to have a good plant. They have to have a good palmar arch. We typically don't like to go on the left. We typically like to go on the left side, not on the right side, because it's such a long distance, and you have to use longer catheters and things like that. We typically also give medications like heparin and nitro and things like that in the radial artery because there's some spasm, and we can avoid that with femoral. But, you know, a lot of my colleagues are very passionate about this. You know, I give the analogy of this is like Duke versus UNC. You know, these people are like, there's a right answer here. It's not like we can try femoral or radial. A lot of them are, there's a right answer. It's radial or it's femoral. We shouldn't be doing this. You know, I do both. I probably do more radial than I do femoral now, but occasionally I still do femoral. And again, it's a discussion with the patients. It's, you know, all those things, other things I mentioned. Like I say, I don't care who wins between Duke and UNC. I'm a Big Ten guy, so I don't care who wins. Actually, I take that back. I don't care who wins as long as Ohio State loses. So embolic agents and endpoints. Basically, we use particulate material. That's how we do it in the US. And it's all basically polymers that are plastics. And these plastics, I listed a bunch of them because there's more and more studies showing that these are equivalent. You know, a new plastic bead comes on the market and it's equivalent to the other one. And that's a lot of the weeds that we don't need to get into, but they're all basically designed to be a precise size, 500 to 700 microns. If you're talking about, you know, adenomyosis, you may want to go to 3 to 5s, things like that. But these are all precisely designed to be a certain size. And the last point I have here is the endpoint. So we used to basically embolize these all the time to complete stasis, meaning there was no forward flow in the vessel. We basically packed the whole vessel with beads. And now we realize that, you know, just a slow kind of sluggish flow in the main uterine artery gives you actually a better benefit, because we can actually cause necrosis of the fibroids, but at the same time, there's less ischemic pain because we haven't completely embolized it as much. So our idea here is to starve the fibroids and preserve the rest of the tissue, because that's really the advantage of uterine artery embolization. The uterus actually functions normally, more like myomectomy, not like a hysterectomy, you know, and there's no reason to cause that much ischemic of the rest of the tissues. So actually this endpoint is very key. This is a big difference as far as pain control afterwards. I'm going to talk briefly about aberrant vascular supply. So most of the time these come from the fibroid. Blood supply comes from the uterine artery. Sometimes it can come from the ovarian artery. And actually, if it comes from the ovarian artery, this can be a cause of failure. So the way we determine that is the MRI again. But there actually have been studies that show, which surprises me, this is a recent study that showed that you can basically embolize the ovarian artery without causing ovarian failure. And in a lot of studies that have shown that really ovarian failure, which is obviously one of the risks we had talked about, it really depends on age. If you're less than 45, in almost all studies, even when they embolize the ovarian artery, there's no ovarian failure, or like 1%. But if they actually are above 45, then it's a higher rate. And then that's what we tell patients. So periprocedural pain. Like I said, uterine artery embolization kind of used to be notorious for pain afterwards. And really, pain is broken down into two things: that immediate postprandial pain caused by ischemia from the embolization, and then post-embolization pain, which is really inflammation that goes on. Once these cells start to die, it causes an inflammatory response that causes pain and fever. And these are really different. And there's different ways we can now control that, both that post-procedural pain, that ischemia, and the post-embolization pain. So we use superior hypogastric nerve blocks, and I'm a big fan of this. And some of my colleagues don't believe in it as much, but I find that it makes a tremendous difference. Basically, what we do here is we take a 21 gauge needle and we advance it under fluoroscopic guidance into the hypogastric nerve area, which is just below the aortic bifurcation, just anterior to the vertebral body. And we test it with a small amount of contrast to make sure there's no intravasation, nothing that goes into the vessels. Then we test it with a small amount of epinephrine to make sure there's no increased heart rate. And then we inject a long-acting bupivacaine, a long-acting analgesic. And that actually gives them a very good pain relief. I can tell you the patients that undergo the superior hypogastric nerve root block, 2 hours later, they're asking me why they can't go home now. And the patients that don't get this, they're saying, why doesn't their PCA work? It's a tremendous difference. And this is one of the ways that we can kind of discharge patients the same day. But then we just have to worry about that later kind of, the later kind of pain that we can deal with. And that usually narcotics and a combination of Motrin, things like that. And then other things that we do. So sometimes after we embolize, we actually administer lidocaine for the same reasons, to get rid of that post-ischemic pain into the artery. And the key to this is actually you administer the lidocaine after you do the embolization, because if you don't, you can cause spasm and you get incomplete treatment. But I actually do this too. I find this is pretty easy to do. So lidocaine into the artery after embolization and this hypogastric nerve root block. These really kind of control that post-ischemic pain. And then steroids too are something. And I personally don't do this as much, but some people, administer steroids prior to the procedure, and that indeed decrease the pain too. I think that's probably working more on the more post-inflammatory pain rather than the ischemic pain, just because of the timing and such, but has also been shown to kind of reduce narcotic use and stuff after the procedure. So these are all things that have really changed, and this makes a big difference. Again, a procedure, I say you're going to go home the same day versus being admitted, even if it's overnight with a PCA, that's a significant change in the procedure. I'm going to just briefly talk about this, and this is actually from our quality guidelines from the SIR. So this is basically a standard every hospital should be meeting, at least, right? This isn't like a good case report. This is the minimum standards, which is 50 to 60% reduction in fibroid size, 40% reduction in uterine size, greater than 90% reduce of bulk symptoms, or bleeding, and about 90% in bulk symptoms. So very successful procedure. And complications, I mentioned amenorrhea already, ovarian failure, early ovarian failure. Most of these things are very, very rare. Pulmonary embolus would have to be almost an AVM. The one thing I mentioned here is fibroid expulsion. I actually have a special slide for that. So fibroid expulsion is obviously after a UAE, there's small parts of the fibroid that are sometimes basically exposed, pushed out. And the case reports vary widely. It kind of depends on if you look at this microscopically and you'll see bits of fibroid, or if you ask the patients that they passed the fibroid. These, it depends on how the study is performed. So there's a huge variation, but this probably happens more closer to 50% of the time if you're just looking at actual tissue being passed. Most of the time, this is totally asymptomatic. Most people, it doesn't cause anything. The concern is that basically these fibroids would basically block the uterine canal. Then those patients could get sick, either require a DNC. It's pretty rare and more common in women who haven't had children. But it's something that we would need, OB or GYN to help us with. And that's one of those reasons that I think, again, closer working relationship. I can think of one case maybe in the last, 5-10 years, but it still can happen. This is a really, I'll save this for last, but this is very controversial, and different providers will tell you different things, but fertility and pregnancy after UAE. So they're actually, I always told patients, I still do, myomectomy is basically the standard that they use, but many people have had uterine embolization and go on to conceive. Basically there's one prospective randomized control trial where they showed myomectomy being superior. This is a pretty flawed study. Almost everyone comments on that. There was an 11% failure rate in UAE, which would not meet any of our standards. I mean, it's just not, it's a procedure we don't, single digits out of thousands that we fail on, really. And this also, if the patients had a fibroid greater than 5 centimeters after they did UAE, they actually went on to myomectomy. And then they only followed the patients for 2 years. And after myomectomy, they had to wait 6 months to try to get pregnant. So if they had large fibroids, they'd probably be shifted from the UAE to the myomectomy anyway. And then they would have very little time to get pregnant. So a lot of flaws with this. then there has been a more recent prospective non-comparative trial which showed similar rates of fertility. So I think it's an option. Again, treatment should be individualized. This is one of those things where, again, collaboration would be beneficial. That is really it. So I thank everyone for listening to this. And if you have any questions or concerns, reach out to me. Thanks for your time.
Thank you, Dr. Swenson, so much for giving us that informative webinar. And thank you to everyone on the line listening in. We appreciate you taking time out of your day. A follow-up email will be sent with a recording of this webinar. And you'll also have Dr. Swenson's contact information if you have any other questions about uterine artery embolization, also known as uterine fibroid embolization. So thank you so much for taking the time to speak with us, and have a great afternoon, everyone.